A warm welcome to one and all. I am Dr. Shanti Ramesh, Professor, Department of Pediatrics, Sree Balaji Medical College and Hospital, and Bharat Institute of Higher Education and Research, Krompet, Chennai. Today I will be talking on dengue in children. The specific learning objectives for this session are to understand the epidemiology and burden of dengue fever, its etiopathogenesis, the WHO revised 2009 classification of dengue fever, to understand the clinical course of dengue infection, how to investigate for a child who comes with dengue fever, how to manage a child having dengue fever, and finally the prevention of dengue infection. Dengue fever is an often asked exam question in the theory paper as an essay, and also for a short note, for a clinical examination, it can be kept as a short case. So with this, I wish you all a happy learning experience. And now going on to the topic, the epidemiology of dengue fever. Dengue fever is otherwise known as the break-bone fever. It's a viral infection that spreads from mosquito to man. Dengue is endemic in over 100 countries in the tropical and subtropical regions of the world. And the transmission being endemic, the transmission occurs throughout the year, as you can see in this figure, but it peaks soon after monsoon season. And that's exactly what we're having today. In Chennai, we had the monsoons and the floods, and here we're starting to see more dengue fevers. So this topic becomes very important and relevant today. Almost about 50 to 100 million cases of dengue infections are being reported every year globally. And this is the epidemiological triad of dengue fever. The agent is the dengue virus, the vector is the Aedes aegypti mosquito, and the host is the human beings. So this constitutes the epidemiological triad in dengue fever. When you look at the geographical distribution of dengue fever, most of the countries in the tropical and subtropical regions are involved, including India. India is highly endemic for dengue fever. Etiopathogenesis. The dengue virus, as all of us know, is a single-stranded RNA virus. It belongs to the family of flavivirus, and there are structural proteins as shown here. And also there are 7 non-structural proteins, of which the NS1 antigen is very important because it's found in abundance in the serum of patients infected with dengue fever, and it's an important diagnostic marker. There are 4 distinct types of dengue virus: dengue 1, 2, 3 and 4. And suppose a child were to get infected with dengue type 1, it produces lifelong immunity against type 1 infection, whereas against the type 2, 3 and 4, there's only short-term immunity going on for 2 years. The first infection which happens, suppose a child were to get first time infected with dengue 1, we call this as primary infection. The subsequent infections with type 2, 3 and 4 are called secondary infection. This becomes important because in primary infection it's usually a mild disease, just fever and cough and cold they may present to you, and that's all. But in secondary infection, all the complications of dengue which I'm going to describe below will be seen. The vector, the Aedes aegypti is the most prominent vector. Also the Aedes albopicticus has been reported in some cases. This is the Aedes mosquito. It's a highly urbanized mosquito breeding in all the water that's stored for drinking purpose, bathing purpose, in the rainwater that's collected in the empty cans and the tires. So it breeds in and around the house, and the transmission of dengue virus is human to human via the bite of an infected mosquito. Now coming to the pathogenesis, it may look like a very complicated slide. I will just make it as simple as possible. As I said, the primary dengue infection, it's just the neutralizing antibodies that are produced and the infection is cleared. It's only with the secondary dengue infection that all this happens. Well, as the virus enters the body, okay, it produces the antibodies which are called non-neutralizing antibodies or infection-enhancing antibodies, which will enhance the virus to enter the macrophages, the mononuclear phagocytes, and this will activate the complement system, release of cytokines. In fact, we have a cytokine tsunami and inflammatory mediators are released, and this acts on the endothelial cells of the blood vessel. This is a blood vessel, causes injury, and hence there's increased vascular permeability, plasma leakage from the capillaries onto the interstitial space. In addition, it also acts on the platelets, resulting in thrombocytopenia. So all this happens during the critical phase of the illness, which I'll be describing later. In 2009, WHO has revised the classification as follows. It has grouped the dengue children into 3 groups. Okay, children, dengue fever without warning signs, children having dengue fever with warning signs, and severe dengue. So what is this? If you look at the dengue fever without warning signs, these are the milder forms of infection. A child who's living in the endemic area, having a short duration of fever for say 2 to 3 days, and if the child has any 2 of the following criteria, then we say the child has got a dengue fever without warning signs. It could be nausea, vomiting, rash, aches and pains, a tourniquet test which is positive, or a leukopenia. So any 2 of these criteria are present, then we say that this child has got dengue fever without warning signs. Then coming to children, dengue fever with warning signs, in addition to all the above criteria, these children will have 1 or more of these warning signs. Then we classify the children having dengue fever with warning signs. Okay, these warning signs I shall explain to you in the subsequent slides. Severe dengue is a situation where there is severe plasma leakage leading on to shock, severe hemorrhage, or severe organ involvement. Now coming to the clinical course of dengue infection. Okay, so after the mosquito bite, there's a short incubation period which varies from 3 to 14 days, followed by 3 classical phases: the febrile phase, the critical phase, and the convalescent phase. The febrile phase lasts for 2 to 7 days. The critical phase is very short, it's only 24 to 36, probably 48 hours, and the convalescent phase which goes on for 3 to 5 days. What I would like you to note is that during the critical and the convalescent phase, the child remains afebrile. So this is very important to note, because as this child who is going to present to you will have 2 to 3 days of very high fever, and following which he becomes afebrile, and just when he becomes afebrile, the child will start entering the critical phase. So understanding that the children are going to be afebrile when they enter the critical phase is important. Okay, just to describe this in detail, febrile phase, dengue is a short duration fever. It lasts only for 2 to 7 days. So any fever that goes on for 10 and 14 days and all that, dengue is not in the differential diagnosis. And the fever is high grade. Okay, we see high spiky spikes about 103, 104, intermittent, it just goes on like that. In some children, the fever can be biphasic. That's why dengue fever is otherwise described as a saddleback fever. So in addition to fever, as I told you, this child is called a breakbone fever. That means it's all about pains and aches. The child will have a severe headache. Most of them complain of headache. Retroorbital pain, again, is very specific. They'll have back pain, myalgia, arthralgia, so much so the child is just lying in bed. And again, there's this classical rash. The erythematous rash is very classical of dengue. And if you press your fingers and let go, you can see this typical blanching. So this is very characteristic of dengue fever. Okay, what you see below is a tourniquet test. Okay, so how do you go about doing a tourniquet test? Okay, we have to inflate the BP cuff midway between systolic and diastolic, hold it there for 5 minutes, and then we need to deflate the cuff. Wait for about a couple of minutes, and in the area of the skin below, you mark out a 1-inch square, and inside this 1 square inch, if you can see 10 or more petechial spots, then the child is said to have positive tourniquet test, and this is one of the diagnostic markers for dengue fever. In addition, these children will have leukopenia and thrombocytopenia. Now coming to the transition from the febrile to the critical phase. This usually happens on day 4 to day 7 of the illness, and it coincides with the effervescence of fever. As I mentioned earlier, this child who's been having high spiky fever will become afebrile, but things are not all right. He's just entering the critical phase. And they may have one of the following signs. Typically, a child come with the warning signs who come to our OPD usually has severe abdominal pain, so much so we may even think it's a surgical abdomen. He's got persistent vomiting, not able to take anything, and he's lethargic. That's the way children come into our department. And in addition, if you do an ultrasound, you may find fluid effusion or an ascites can be detected. Sometimes they may present with nasal or epistaxis or a gum bleed. And liver enlargement again is quite significant. They may have a huge liver, 3 to 4 centimeters, tender liver may be present. In addition, if you go to labs, a rapid decrease in the platelet count during the critical phase is very characteristic. We would have done a platelet count in the febrile phase, it would have been something like 1.52 lakhs. All is well. But as soon as they enter the critical phase, within 24 hours, the platelets come down very rapidly to something like 20 or 30,000. And a racing hematocrit is also important. If you've done a baseline hematocrit, a 20% increase in the hematocrit from the baseline becomes clinically significant. What exactly happens in this critical phase? As I've explained to you in the pathogenesis, there's increased vascular permeability, increased plasma leakage, and as a result of which there is compensation this results in hypovolemia, so the body compensates by raising the diastolic pressure, resulting in a narrow pulse pressure. So this is the time we need to intervene early. So when a child comes into our OPD, he's had a bout of fever, now he's afebrile, he's coming in with warning signs, particularly having severe abdominal pain, vomiting, not able to take anything, he's lethargic, and when you do an ultrasound you find there's a plasma leakage, there's an effusion, an ascites, and blood pressure shows a narrow pulse pressure of less than 20 millimeters mercury. This is the kind of situation we need to pick up. This is the early phase of the critical, this is the early few hours of the critical phase, and at this point of time, if you can give them appropriate fluid resuscitation, then all these children can be saved. If this can be done, the mortality to dengue fever can be reduced to 0. It's so important and so critical, this step is. If you let go and if you don't identify and let go, then the child slips into a phase of shock. It goes in for irreversible shock, and the situation is quite difficult to manage beyond this. And the whole critical phase, as I told you, lasts only for 24 hours. It's the first 24 hours afebrile after the spiky fever. That's the time the capillary leak is maximum. It is very dramatic, very sudden, and that's the time we need to act fast. The next 24 hours, the leakage is quite slow, and by 36 to 48 hours, the plasma leakage will stop. All is well. The child now moves into the convalescent phase. This phase, all the fluid that's extravasated in the extracellular fluid gets back into circulation. So the child becomes stable, the vitals are stabilized, his appetite is back to normal, and things are all well. And the recovery phase just takes about 2 to 4 days. And at this time, you may see a second rash, and this rash is typically called as isles of white in a sea of red. So during this phase, the child is well, and it's just 2-3 days, and they're all up and about, and they can go home. Just to recapitulate, we have 3 phases in dengue fever: the febrile, the critical, and the recovery phase. During the febrile phase, it's a very high fever, and as the child becomes afebrile, or even child is becoming a little hyperthermic, that's the time the plasma leakage will start. That's the time we have the warning signs and all the plasma leakage effusions and the low pulse and the narrow pulse pressure, and we need to intervene early. Otherwise, the child goes in for shock, organ impairment, and we may not be able to save these children. At the same time, when you look at the labs, there's a rapid fall in the platelet count, as I told you earlier, and a rapid rise in the hematocrit count. Now coming to laboratory investigations. If a child presents to us in the first 5 days of the illness, doing an NS1 antigen by the ELISA method is confirmatory. If the child presents beyond 5 days of fever, then we need to do a IgM antibody by the ELISA method, and that becomes confirmatory. So either looking for the NS1 antigen or the IgM antibodies by the ELISA method is confirmatory for dengue fever. The other investigations which will support the diagnosis of dengue fever includes doing a complete blood count, where you can see a leukopenia, WBC counts as low as 2000, platelet counts less than 1 lakh, but usually we see them in the range of 20 to 30,000. A hematocrit, okay, baseline hematocrit, if you have a 20% raise above the baseline is significant, and serial hematocrit also should be done to titrate the fluid therapy. OTPT will be raised, and when you do a chest x-ray, as you see here, we can see a right-sided pleural effusion. It's usually a right-sided pleural effusion more than the left. Occasionally we can have a bilateral pleural effusion. Ultrasound abdomen will show the same. You can pick up the fluid, pleural fluid, as well as the ascites and gallbladder wall thickening due to increased vascular permeability. Management. We need to understand that dengue viral infection in children, most often it is asymptomatic. Okay, so they have no symptoms and we don't diagnose. So it's only a small percentage, maybe about 20-25% of them who are symptomatic. And as I told you, this mild disease corresponds to dengue fever without warning signs, and such children can be managed at home. Okay, the moderate disease corresponds to children who have warning signs, as I described, or having high risk of comorbid conditions. So what are these conditions? If it's an infant who comes to you with dengue fever, yes, your antibody is going to be up, you're going to admit. If it's an obese child, yes, again, we're going to admit. A child who's on steroids, or child is got immunocompromised state like an HIV, or he's on anticoagulants or antiplatelet therapy, in such situations, dengue can be quite severe and we need to admit these children and monitor and treat them. Of course, severe dengue is a situation that calls for a tertiary level care, okay, maybe in the pediatric intensive care, because these children require continuous monitoring and treatment. Okay, a word about the home treatment. As we all know that dengue is a viral infection and we do not have any antiviral drugs against dengue infection. Okay, for the fever, we can give paracetamol. Drugs like aspirin and NSAIDs should not be given. It's contraindicated because they cause platelet dysfunction and make the hemorrhage worse. And hydration, dengue, all children with dengue fever should be encouraged to take a lot of fluids, including ORS, and the parents should be informed about all the warning signs, so that if they identify any of these warning signs, they get back to the hospital immediately. Now coming to the second group of children who will be admitted, we shall see how to monitor them and treat them subsequently. Dengue fever with warning signs. So these are children you're going to admit, and we will try oral fluids. Most often they are having severe abdominal pain, they're continuously vomiting, they're lethargic, they're not able to take oral fluids. Such a situation we normally see. And in such situations, we start them on isotonic fluids, and the fluid of choice in dengue fever is normal saline. So we start them at 7 ml per kg per hour, and as the child improves, we monitor, and as the child improves, we step it down to 5 ml per kg per hour, and then to 3 ml per kg per hour, and then finally we put them on a maintenance of 1.5 ml per kg per hour, and we continue fluids only through the critical phase, probably 24 hours to 48 hours, after which things will settle down and we stop our IV fluids. If the child doesn't improve and the hematocrit is increasing, then we need to give a small bolus, after which they should improve and we come down on the same pathway. And what do you mean by improvement and what do we monitor? So things that we monitor are, we look for the sensorium, the child should become more alert, more responsive, then all the vitals. Okay, if the child has got tachycardia, it will settle down, tachypnea will settle down, and when you look at the blood pressure, the pulse pressure, now it is narrow, now it becomes around 30, which is normal for children. A 30 millimeter pulse pressure is important for good perfusion of the vital organs. And then the urine output also is very important, a bedside tool. Okay, so we normally ask the mothers to collect urine, and the urine output is more than 1 ml per kg per hour, then we reassure that this child is improving. So, having told so much, we don't want to see children in shock. So we want to identify children in the early phase of in the early few hours of the critical phase, treat them so that they recover straight away. So if that is delayed, then unfortunately we get into the stage of shock. Okay, here the child, when you say it's a compensated shock, the systolic blood pressure is maintained, but they'll have signs of poor perfusion by cold extremities, cold clammy extremities, a delayed refill, low volume pulse, altered sensorium, and it will be a low perfusion. So in giving oxygen first, and then we need to give them isotonic crystalloid solution, normal saline fluid of choice. We start them at 10 ml per kg per hour for 1 hour. Improvement, go through the same pathway as I told before. If they don't improve, okay, you need to check the hematocrit. If it's high, a second bolus, sometimes the third bolus may be also required, after which children improve and they go on to this pathway. Sometimes, in spite of 2 boluses, they'll be still hyperperfused. And in such situation, when they're hyperperfused with a low hematocrit, then you must look for overt focal bleed. It can be a GI bleed or menorrhagia. So in such situations, blood transfusion becomes important and life-saving. Hypertensive shock, it's an extremely difficult situation. The blood pressure is down, the systolic blood pressure is not maintained, and the child becomes drowsy. Oxygen, once again, more fluids. The boluses will be 20 ml or 15 minutes. Improvement, the same pathway as before. Not improving, the same pathway as I told you before. So here's a child who's got a hypertensive shock, and as you can see in this picture, the child is so sick. He is edematous. You can see there's an ascites, and he requires a lot of support. This child is intubated. He's got a central line in place. He's also catheterized. So this child requires a lot of support, monitoring, and care. And in spite of best of the efforts, still some of them, may not do well. So we don't want to get into a situation. We want all the dengue children should be identified early in the critical phase and give them appropriate fluid so that we don't get into the shock situation. Then how to manage bleeding. Bleeding is not so very common in pediatrics. It's only about 10% of children who have bleeding. And this is because of they go through a period of uncorrected shock, and then only all this happens. So GI bleeds, if they have an hematemesis, melena, or a massive epistaxis, or if an adolescent girl having a heavy menstrual bleed, in such situations we need to give blood transfusion urgently to save lives. Regarding platelet transfusions, we have very specific indications. So previously, any dengue fever will also receive platelets. Once the diagnosis is made, they are in for platelets. But today, the platelet transfusion indications are very stringent. So platelet transfusion is given only to those patients with severe thrombocytopenia, which means a count less than 10,000 per cubic millimeter in the presence of active bleed. So thrombocytopenia with active bleed, we give platelet concentrates. Otherwise, there's no role for prophylactic platelet transfusion. The criteria for discharge, we have done a good job. The child is ready for discharge, he's afebrile, he's sitting up in bed, having good appetite. The mother shows you the urine can, there's adequate amount of urine that is passed, no distress, and the platelets are gradually rising up. And if it's more than 50,000 cells per cubic millimeters, then this child can be discharged. And usually, they recover so fast, within 2 to 3 days of the critical phase, they are ready for discharge. Prevention. As of now, we don't have any vaccines. So there's no vaccine against dengue fever for clinical use. So we have to depend upon public health measures. And now we have the National Vector-Borne Disease Control Program by the Government of India, which tells us to do the integrated vector control approach for the mosquitoes. So mosquito controls would be anti-larval measures, particularly to take care of all these breeding sites in and around the houses should not be there. We should clean them up. Anti-mosquito measures, this is done by the you can see soon after the rains in the monsoon season, you can see our public health people will come in and do this flogging for us, with insecticides like malathion. And personal protection becomes also important. We need to have long clothing and use mosquito nets for the houses or individual mosquito nets with repellents. So to make sure that all these are in place, we have these 3B clause. So prevention is most important in dengue fever. Now to conclude, dengue is a rapidly emerging disease. Almost half the world's population live in dengue endemic areas. Early identification of the warning signs, appropriate fluid management is very critical in the management of dengue fever and in saving lives. Public awareness to control mosquito breeding sites, personal protection against mosquito bites, and public measures like fogging with insecticide will go a long way in the prevention of dengue fever. Thank you very much for the patient listening.